This is the second of two cardiovascular lectures, and in the last presentation we talked about cardiac output, and we recognized that cardiac output is equal to stroke volume times the heart rate. And then I talked about a number of different factors that influence the heart rate and the stroke volume, and therefore also regulate cardiac output. We're going to continue thinking about cardiac output. You also learned about the EKG and the different waves of the EKG. And again, in lab this coming week, you'll learn a lot more about the EKG, how to read them, and also look at a number of abnormal EKGs. We're also going to be looking at how that cardiac output is affected by pressure and by resistance of the vessels. And we'll talk about total peripheral resistance, blood flow, and what happens to that blood and fluids in the capillaries and the spaces in the interstitial spaces. Finally, we'll finish up this talk in this chapter with understanding how your blood pressure and how blood flow is regulated, and finally talk about both the baro and the chemoreceptors. So obviously your heart rate and your blood pressure are very, very important and are being maintained through homeostatic mechanisms. And that's really what we're dealing with here. We're talking about a number of different ways that the body is keeping in check your blood pressure and therefore your perfusion. That is how much blood is getting to your tissues, especially your brain, your kidney, your liver, your critical organs that need constant blood flow. So you must generate enough pressure from the heart to force blood through miles of capillaries found within your tissues. And you have two circuits within your body. You know that you have the systemic circuit as well as the pulmonary circuit. So you need to keep blood in all of those. And we have to control this through some nervous system and endocrine system mechanisms. So both of these systems are working to ensure that your cardiac output is sufficient to meet the demands of your tissues. Again, you have to have enough blood flow going to your brain and to your heart, muscle itself, to the liver, to the kidney, and to all of your tissues to maintain normal function. Recall that you only have 5 or so liters of blood in your body, and recall our conversation on the autonomic nervous system in the past, and you know that the body can shunt blood from some areas to other areas depending upon metabolic needs. So for example, in a sympathetic surge, more blood is going away from your digestive organs but going to your muscles. And during a parasympathetic surge, more of that blood is being now redirected toward those reproductive and digestive organs. And so the body has to make a choice as to where it needs that blood at that particular moment. Remember, the sympathetic and the parasympathetic systems are never completely on or off, but are simply this constant rheostat, adjusting the amount of blood going to your tissues. So this neural and hormonal control will certainly affect your heart rate, will certainly affect the stroke volume of the heart, as well as resistance and pressure going to other organs. Now, every time your heart goes through a cardiac cycle, there's going to be a pulsing of your blood that is generated. And that's going to lead us to the idea of blood pressure. That is, how much pressure is being put on your vessels as the blood is being pushed under pressure to your organs. So there's an atrial pressure coming from the atria and the ventricles are going to push the blood out into your arteries. So the arterial pressure is going to be much higher than your venous pressure. Recall from 105 that the arteries are under greater pressure. They have a thicker tunica media, a thicker muscle layer. And you may want to review your artery and vein structures as we talk about these differences. And that pressure in the arteries will be much greater than the pressure in the veins. Remember that as blood pressure, as we leave the capillaries and come back through the venous system, that the pressure essentially drops almost to zero before coming back to the heart. It's only through the valves, through the skeletal muscle pump and through the sucking of the heart itself that blood is able to come back to the heart. Now, how much resistance the blood faces as it's traveling through the vessels is going to have a big part on how the flow of blood moves through blood vessels. So resistance is the opposite, if you will, of movement. It's the flow. Peripheral resistance is simply the resistance of the interior of the entire arterial system. So as the vessels get smaller, this resistance will get larger. If there's any kind of buildup on the walls of your arteries, then that'll make it more difficult for the blood to pass through. If the vessels become less compliant or become more stiff, that will also make it more difficult for the blood to flow and increase the resistance. All of these factors, if you increase the resistance, would be afterload. So go back and look at afterload. Afterload was a factor that influenced cardiac output and stroke volume. It made it more difficult for the blood to pass out of the heart. So blood flow in capillaries is quite slow, even though, and the pressure is quite low. Okay, so this is a low, slow movement through the capillaries. The pressure is quite low, and it's here in the capillaries where gas exchange happens. But not only gas exchange, but also fluid exchange and nutrient exchange. Remember, the capillaries are only one layer thick. All they are is an endothelium with just enough basement membrane to glue them together. So they're rather delicate and they can be rather leaky. There's no tunica media, there's no muscle layer around the capillary. So this allows for diffusion of molecules in and out from the capillary bed. Now, I mentioned already that blood comes back to the heart and that pressure is maintained by valves that are located in a number of the larger veins, as well as compression of those veins, and that refers to the skeletal muscle pump. So as blood comes back toward the heart, the vessels are getting larger and larger, eventually all draining back into the superior and inferior vena cava, and there, because of the much greater lumen size, then the resistance will decrease. The amount of blood arriving back at the right atrium each minute is going to equal essentially your cardiac output. Think about that for a moment. This is one big cycle, one big circle. So the amount of blood going out of the heart must equal the amount coming back into the heart. Cardiac output was stroke volume times heart rate. It was measured in milliliters per minute, and that same amount of blood would be coming back to the right atrium every minute. So this is just showing you total pressure, if you will. So as blood is leaving the heart, it's going to go into the arteries, and that's going to be a significant amount of pressure that is being countered by the amount of resistance. So the lumen in the artery is also much smaller, so that also increases the resistance. However, by the time we get down to the capillaries, fluid is moving much more slowly, and that is because at first you might think, well, aren't we trying to squeeze that blood into a smaller vessel? And that is true. But what you need to realize is that your arteries going down to the arterioles, going down to the capillaries, there's miles and miles of capillaries within your body. So while each individual capillary vessel is smaller, the sheer number of them and the amount of space or volume into which that blood is spreading is very significant. So that slows down the rate and the pressure in the capillaries. Coming out of the capillaries, the pressure is already rather reduced. We go into the smaller venules, the small veins, and then back into the larger veins, which again, because of their large lumen, have very little resistance and very low pressure, and then back into the right atrium. Now, what is going to be influencing this whole system? Definitely the nervous system we'll see, and the endocrine system. Specifically, we'll be looking at a hormone made by the kidney. So let's talk about how this resistance, what is it that influences the resistance of blood flow? The resistance is in the entire resistance of the entire cardiovascular system, and the heart must pump sufficiently to overcome this resistance. There are three factors that are going to influence the resistance. The resistance of the vessels themselves, the vascular resistance, how thick the blood is, the viscosity, and the turbulence of the blood. Let's go through each of these. So, vascular resistance, the opposition to blood flow within the vessels. This is the big one. This is the big one. You know, there's some friction being built up between the blood and the walls of the vessels, and the two things that influence that friction, that resistance going through the vessels, is going to be the length of the vessels. The longer the vessel, the greater the resistance, and the diameter. The bigger the diameter, the resistance goes down. The smaller the diameter, the resistance would go up. Well, let's talk about this for a moment. There's definitely some friction between the vessel walls and the moving blood. And so if you increase the length of the vessel, that would increase the surface area, and that would increase the friction or the resistance. But the length of your vessels as an adult is considered rather constant. You're not creating new vessels. Well, you are creating new vessels, but the overall length of your vascular system is thought to be rather constant. So as an adult, this really doesn't have much of an effect. Yes, there are some changes between birth and maturity in this, but once you get to an adult, this is not, the length of the vessels is not considered to be a significant player in this discussion. So as you can see, right, flow is going to, it's going to be flow that goes through the vessels, and here, right, this is about half the length, so we're going to say the internal surface is equal to 1. If we double the length of that vessel, then that surface area would double, and flow would be reduced. Okay, so again, they're inversely related. So the surface area is inversely related to the flow. Now, while diameter doesn't play much of a factor, probably the largest quickly changing thing is the diameter of your vessels. In smaller vessels, more fluid is up against the wall, so there's higher resistance. In larger vessels, there is a large part of flow that is not affected at all, so the resistance goes down. Now, you know that friction and vessel diameter, imagine this picture, and the flow in the center of this vessel, the flow in the center would have the least resistance, right? Around the outside edge, there'd be the greatest resistance or the slowest flow. Well, this is changing all the time. You know that your vessels undergo vasoconstriction and vasodilation. That is, your sympathetic and parasympathetic nervous systems are going to be influencing the amount of flow to your tissues. Now, we've talked about that. You know that when the bear is chasing you, more blood is going to your muscles and less is going to your kidneys, and vice versa in the rest and digest. Well, how is it that happens? Is the vessels change their diameter. So there's a constant change in the so the relationship here is radius to the 4th power. So the resistance is equal to 1 over radius to the 4th power. So if the radius changes, let's say the radius was 1, so that would make, if the radius was 1, then the resistance would be 1 over 1 to the 4th power, which is 1, right? The whole thing is 1. But what if the resistance, so what if the radius is now 2? If the radius is 2, then the resistance is going to be changed by 1 over 2 to the 4th power. Well, 2 to the 4th power is what? 2 times 2 times 2 times 2. So you can see there's a huge difference in the resistance, the change in the resistance due to the radius. Again, this is how the sympathetic and parasympathetic nervous systems are going to regulate blood flow to different organs. That is demonstrated here with the math already done for you. So if the total here if the diameter is 1 or if the diameter is 2, you can see what happens. So the resistance is far different. Remember, diameter is twice, right? Radius, if this is the circle, and there's the center of it, diameter is from side to side, whereas the radius is just half of that. So here, a diameter of 1. Again, we're seeing a doubling of the radius, so that has a change of resistance of a factor of 16. Viscosity. Yes, viscosity can affect blood flow or resistance. Again, though, there's not going to be a big change, a big dramatic change in your blood. So it is true that a lower viscosity fluid would have less resistance, think water, which has a viscosity of 1, versus some sort of molasses, which has a much higher viscosity. So it would have greater resistance and would flow only at higher pressures. We can appreciate that from our everyday experiences. Certainly it's going to take a lot more pressure to push honey or molasses through a vessel than it would water. But from day to day, the viscosity of your blood, which would be mostly affected by the number of blood cells and the amount of protein in your blood, is not going to be changing dramatically. So yes, it has an effect, but it's not going to be a huge effect. So because your viscosity of blood is certainly greater than water, but the viscosity is relatively stable within your body. There can be disorders, and we'll talk about them. Anemia, low red blood cells, or polycythemia, high red blood cells. Yes, it can change your viscosity, but it's not something that happens immediately. And so, while it can affect viscosity, it's not going to be a major player. So again, just to show you this visually, molasses, maple syrup, or oil, right? They're much more viscous than water and blood. So it's going to take a lot more pressure to push these thick fluids through a tube or through a vessel than it would for water or blood. The last is turbulence. And turbulence is flow with, as you can imagine, some swirling and some irregularity to it. And this is going to be, turbulence will be caused by high flow rates. So if you're going down the rapids in a boat of some sort, you know that if you're flying along, you're going to have greater turbulence. And this is going to be caused by irregular surfaces of rocks and things in the river. And also, if you're ever going down a raft and the river narrows a little bit, you know that at that place, because there's less of a diameter of the river, that the turbulence will increase. And this turbulence is what's going to produce a little bit of the heart sounds, especially the third and fourth heart sounds that we haven't dealt with very much here. There is a normal turbulent flow to blood in the heart. However, again, this is not going to be a major issue from day to day in the flow of your blood. If you have increased turbulence, you will have increased resistance, and that will slow the blood flow down. And there is, therefore, a little bit of slowing of blood in the heart because of this turbulence. So you can imagine that valves would also do this. So the blood's coming in. Here we're showing some plaque. If there was plaque on the inside of a vessel, that would certainly increase the turbulence. Imagine too, this is a valve, and that valve would also increase the turbulence. And like I said, that is the sound that you're hearing in the heart. Lub-dub, lub-dub. Sounds 1 and 2 are thought to be attributed to both the turbulence as the valves close and that flow of blood being abruptly stopped, but also the percussive closing of the valve. So collectively, the percussive closing and the turbulence caused is what produces the heart sounds. Now, the flow of blood will be directly proportional to your blood pressure. Increase the pressure, increase the flow. And flow will be inversely proportional to resistance. If you increase the resistance, you will decrease the flow. The major player, what's pushing blood through the body, is this idea of a pressure gradient. That is, things are going from a higher pressure to a lower pressure. The greatest pressure is at the aorta, and going down to the capillary beds, that pressure is going to decrease, and then even decrease on the other side of the capillaries coming back in the veins. So a change in pressure will absolutely change the flow. And we're going to be talking about now how this pressure gradient can be altered by the Cardiovascular Center. Okay, and I'll introduce the Cardiovascular Center to you in a moment. And this change of flow is going to be adjusted in part by the cardiac output and by resistance. There's definitely going to be a change in the diameter as well. The aorta, is a big garden hose about 1 inch in diameter coming out of the heart. The capillaries are microscopic. And coming back again from the capillaries to the vena cava, that we're going to decrease the resistance. And if we decrease the resistance through the increasing diameter, then we will increase the flow back. So from the heart down to the capillaries, things are getting slower, right? Slower, down to the capillaries. And then as we come back to the heart again, things are going to get faster again as they come back through the veins. So arteries get slower and slower, the veins get faster and faster back to the heart. The highest pressure is at the aorta. We talk about pressure of 120 over 80 being sort of an average pressure. That 120 is the systolic pressure, or the pressure of contraction leaving at the heart. So about 120 millimeters of mercury. And the pressure will drop as it goes through the branching arteries and then to the arterioles. By the time we get down to the capillaries, the pressure is down to about 35 millimeters of mercury. At the venules, it's down to about 18 millimeters of mercury. And by the time it comes back to the vena cava, it is nearly 0. It is not possible, you would not want to, I should say, change the diameter of the aorta. It's a big vessel. You would not want to restrict or constrict the aorta as a way of regulating blood pressure, because that's going to control the entire body. If you want to make changes to blood pressure to certain organs, it makes sense that you would do so down at the smaller arteries and the arterioles and even at the capillaries. There you would have the greatest amount of control to change the flow to one area of the body while not affecting the other, or maybe to increase it to another area. So looking at this diagrammatically, you can see that here we have the diameter on this axis, and the diameter of the aorta is largest, coming down through the arteries, arterioles, it gets smaller. The diameter of the capillaries is smallest, and then we increase as we move up through the veins. This is the blood pressure. Blood pressure is greatest at the aorta, rapidly drops as we enter into the capillaries, somewhere around 40, leaves the capillaries somewhere around 20 or so, 18, and then slowly drops down towards 0. And then finally here is the velocity. So we see an increased velocity leaving the heart under great pressure, drops down at the capillaries, and as it returns back to the heart, it does in fact increase. Not to the same, right, it doesn't increase back to where it was, but it's certainly a much greater flow rate than it was in the capillaries. So how would you change the pressure? Well, I could increase the ventricular systole, right? That is, make the heart squeeze harder in leaving the left ventricle. So that would increase the pressure. I could also change the pressure in the arteries by the lower pressure that's in the ventricular diastole. So the pressure in the vessels will certainly drop when the heart is at relaxation. And again, 120 over 90 as an example, or 120 over 80. The 120 is the systolic, the 90 is the diastolic. This is the pressure during contraction. This is the pressure on the vessels during relaxation. Pulse pressure is simply the difference between the systolic and the diastolic pressure. So if the pressure is 120 over 90, simple enough, I just subtract the two, and my pulse pressure is the difference, 30 millimeters of mercury. Now remember that your heart, if you go back and look at the cardiac cycle, is in diastole longer than it is in systole. So if we want to talk about the mean arterial pressure, what is the, quote, average pressure on the arteries, we do so using this equation. Basically, you take the diastolic pressure, 90, and to it, you add 1/3 of the pulse pressure. Okay, so in this case, easy numbers here. So 90 is the diastolic pressure, and 1/3 of the pulse pressure here was 30, 1/3 of that is 10. So the mean pressure, the mean arterial pressure, the MAP, would be 100 millimeters of mercury. So here you see the 120 over 90, 120 over 90. This up and down, up and down, up and down is what's happening. You see that the mean arterial pressure, started at 100, is dropping. Okay. And notice that the pulsatile nature of this disappears. So leaving the heart and going through your brachial artery, going through your femoral artery, through your muscular arteries, you're going to have this pulsation. By the time we reach the capillaries, there's really no more pulsing of the blood. So the blood is now going to be dripping through the capillaries at sort of a steady state, not pulsing in. Remember that the capillaries are very, very delicate, and you would not want to have a large pressure difference in those very delicate capillaries because you could very easily damage those capillaries. So by the time you get to the capillaries and from that point on, there's really no more pulsing of the blood. It's now more of a steady state. And again, the mean arterial pressure is the diastolic pressure plus 1/3 of the pulse pressure. That's an equation you'll want to remember. So when we finally get down to the capillaries, you know that that's where gas exchange happens, but there's also water exchange here. This is where your capillaries and your lymphatic vessels are communicating one another. And also this is where proteins and glucose and other nutrients are being exchanged as well. So within the capillary bed, there is going to be a hydrostatic pressure. Now, when I think about hydrostatic pressure, hydro, water, I'm thinking about the force of the water on the blood. So you know the blood is coming from the aorta under pretty substantial pressure, and I told you that at the capillary, we're somewhere around, at the beginning of the capillary, somewhere around 40 millimeters of mercury going into that capillary bed. So that's the pressure that's being pushed by the heart into the capillary bed, and that's going to drive molecules out of the capillaries and into the interstitial space, the space around that capillary bed, down into the microscopic tissue. It's going to push water, it's going to push small molecules out of the bloodstream and enter that interstitium or the interstitial fluid. Larger molecules like plasma proteins, albumin for example, would remain largely in the blood because, again, the capillaries here are continuous capillaries. These don't have typically fenestrations, And so there isn't much of a space for larger molecules to move out of these capillaries. Water and small molecules, however, can move out of the bloodstream and into the interstitium. So in this cartoon, again, we're just seeing that the endothelial cells, right, the cells lining the capillary bed, have a little bit of leakiness between them. So here's what's in the blood. We see some water, we see some other small molecules, and they are able to slide between those cells and get out into the interstitial fluid. So ions, maybe some small glucose molecules could get out. Amino acids could get out. Larger blood proteins like the albumins and others, immunoglobulins, would certainly not be able to get out. And that is being pushed, if you will, through this capillary hydrostatic pressure called the CHP. Now, at the capillary, there's a lot of exchange going on. Remember, not only diffusion of molecules under that CHP. Now, what is going to allow for greater diffusion? If the distance is short, and remember, all we're doing is the capillary is lined by endothelial cells, so there's not much of a distance for this to travel. So distances are short, so there'll be rapid diffusion. The concentration gradients, remember the concentration gradient, how much difference there is between the high and low concentration of the molecules, and the size of the molecules themselves. All of those are going to influence how quickly diffusion of these molecules can occur. This is happening along the entire capillary bed, but there are different transport mechanisms for different substances along this vessel. So again, here are the rules, if you will, or the routes of diffusion. So water, ions, small molecules, glucose, amino acids, urea will enter and leave, no problem, between the endothelial cells. Some other molecules can also pass through those endothelial cells by channels that are present. Large molecules would be unable to leave unless they are in fenestrated capillaries. Remember, fenestrated capillaries are going to be found at your endocrine organs, like the hypothalamus, and they're going to be found along the intestines for nutrient absorption, and in the kidneys at the glomerulus, but not typically in your regular capillaries. Lipids and those molecules, of course, can move because they can move across the hydrophobic membrane. And again, larger plasma proteins typically would not be able to move, again, unless they are in the liver, where you would have sinusoidal or discontinuous capillaries. Now, at the arterial end of the capillary, in other words, there is an arterial end and a venous end of every capillary bed. Where the blood is first entering into the capillary bed, that'd be the arterial side. That's where there's the greatest pressure. Right? I told you before that the pressure is dropping from about 40 millimeters of mercury down to about 18 millimeters of mercury as it goes through the capillary bed. So the capillary hydrostatic pressure is greatest at the arterial end. So that's where the greatest number of water and solute molecules will enter into the interstitium. Now, there's another pressure that's in here as well. As that filtration occurs, the blood colloid pressure is going to increase. Now, remember from Lab 2 of Biology 105, the idea that solutes suck. As you lose water at the beginning of the capillary bed, that means that the protein and solute concentration within the blood is going to be increasing. And as that protein concentration increases, it's now going to start sucking blood back into the capillary. So that is the blood colloidal or colloid osmotic pressure. So as water is leaving on the arterial end, the plasma proteins remaining are going to increase that colloid pressure, and that's going to start sucking water back into the vessel back at the venous side. As long as the capillary hydrostatic pressure is greater than the blood colloid osmotic pressure, then fluid will be forced out of the capillary. However, once those are equal, then there would be no flow, no movement across. So we're talking about the net filtration pressure, okay, the NFP, and that is simply the difference between these two pressures. So the net filtration pressure is equal to the capillary hydrostatic pressure minus the blood colloid osmotic pressure. At the beginning of the capillary, it's positive, and so you have a lot of filtration. However, at the far end, at the distal end of the capillary, now this number is going to reverse and become more negative, and now reabsorption will occur. And reabsorption is the idea that those solutes are going to begin to suck water and some other molecules from the interstitium back into the capillary bed. At roughly 2/3 of the way along the capillary, there's no movement because the net filtration pressure is 0. Okay, if there's no difference in the pressure, then flow will not occur. So at the venous end or the venial end of the capillary, reabsorption will be the predominant process that's happening. The capillary hydrostatic pressure has dropped below the blood colloidal osmotic pressure. Water will move back into the capillary. Now it turns out that there's always more water leaving the bloodstream than is reabsorbed. And this fluid that leaves the capillaries but does not get reabsorbed back into the capillaries is going to enter into the lymphatic vessels. So around your capillary beds also are lymphatic vessels, microscopic lymphatic vessels that are collecting this fluid, and that becomes now your lymphatic fluids, and that will eventually be returned back to the venous system. But there's about 3.5 liters a day of this fluid, and that represents the 3.5 liters or so of lymphatic fluid that you are utilizing every day. So to take a picture of this, get a mental picture of this, here's the blood coming in through the arterial, coming into the capillary bed. Here the capillary bed is shown as one large vessel. Keep in mind capillary beds are typically can be up to hundreds of microscopic capillaries working in conjunction together. But showing here for simplicity, we have one large capillary. On the red side, this would be the arterial side, and here there'd be greater pressure pushing solutes out and water out. So filtration is going to predominate, and here we'll have a net filtration pressure pushing stuff out, okay, out into the interstitium. Now what's not shown here is that there would be, and I'll go ahead and put it in green, there would be some lymphatic vessels out here, okay, around the capillary bed in green. I'm putting them as green, and they're going to be collecting some of this fluid. Now about 2/3 of the way through the capillary bed, there's going to be no net movement. So no net movement about 2/3 of the way in. And then at the far end, at the distal end, at the venous end, you see that the blood colloid osmotic pressure increases over the capillary hydrostatic pressure, and that's going to now draw water and other molecules back into the blood. And this is reabsorption. But notice that the reabsorption is not going to bring back all the fluid. So some fluid, again about 3.5, 3.6 liters per day of fluid in all of your capillary beds is going to remain out here in the interstitium, and that fluid is going to find its way into the lymphatic vessels, become part of your lymph. Now not only is, when we think of capillaries, we usually think of simple squamous epithelium and gas exchange. But now I'm trying to convince you and prove to you that not only is gas moving, but also, because oxygen is not being shown here, all we're talking about here are the fluids, but you also have water and nutrients exchanging here at the capillary beds. Now there can be variations on this theme. Any condition that affects the blood pressure or the osmotic pressure of the blood, or can change the interstitial fluid balance, can cause some big changes in the capillary exchange. If there is a hemorrhaging occurring, that is, there's blood somewhere, that would decrease the CHP, and now there would be increased capillary reabsorption, right? So you're going to pull that fluid from the interstitium back into the bloodstream because the pressure has been changed. So if the CHP is reduced, reabsorption would increase. What if there's dehydration going on? And also the volume of blood and the blood pressure is decreasing. That would also increase the blood colloid osmotic pressure. So you begin to see that these two are connected together. If the pressure is higher, if the blood pressure is higher, then that's going to decrease, or if the blood colloid osmotic pressure decreases, then that is definitely going to affect and can build up fluid. So if your CHP is increasing, that means that more fluid will be pushed into the interstitium, and that would increase fluid in your tissues, and we would call that edema. Now that could be an increase in CHP, or that could be a decrease in blood colloid osmotic pressure, or a combination of either. Okay, so now that we have an idea of what's happening at the capillary, that there is this pressure pushing water and molecules into the interstitium at the proximal end and the distal end, there is flow back in or resorption back into the capillary. Let's talk about the two main ways that we can regulate all of this. So we need to be keeping our perfusion of our tissues adequate. And perfusion is basically the amount of blood flow going through your tissues. It's going to be measured in milliliters or liters per minute per gram of tissue. And we won't be measuring or calculating any of that. But we need to make sure that our blood and oxygen levels are sufficient for all of the tissues. And there's two ways that the body maintains this regulation of blood flow and perfusion. And that is, there's autoregulation, and that's going to occur basically at the local level. And then there's central regulation. That is when the brain, nervous system, and the endocrine system and hormones are activated. Now, the capillaries will first work with autoregulation. And if autoregulation is sufficient, then fantastic, nothing has to happen. There's no nervous or hormonal signals necessary. But if for some reason the autoregulation is not enough, then that will activate the central regulation with the use of nerves or hormones. So let's first look at this autoregulation. That is, blood flow is going to change within a capillary bed without signals from the brain or from the endocrine system. And basically at the proximal end of every capillary, there are some precapillary sphincters. These are smooth muscles that wrap around the vessels going into the capillary bed, and they're going to squeeze and therefore restrict fluid, blood into the capillary, or they're going to vasodilate and therefore allow more blood to flow in. And this can happen locally. So there are local chemicals that increase the blood flow. If you vasodilate, vasoconstrict would decrease the blood flow. Now, that's what is happening. It's happening all the time. There's a certain amount of those precapillary sphincters that are opening and closing. Again, if that is sufficient, fantastic. However, if that is not supplying sufficient blood flow to the tissue, then these central systems will kick in. So you can have a neural signal, and that is going to activate the cardioacceleratory centers, and this is going to activate or control that peripheral vasoconstriction. And this can either increase cardiac output or reduce blood flow to non-essential or inactive tissues. So if you need more blood flow to your muscles, then you would increase the flow to the muscles but also decrease the flow to the other tissues. And then there are also vasoconstrictors, primarily norepinephrine, which can also travel through the blood and will change blood pressure to certain areas as needed. So there's a few slides coming up where you're going to have to just kind of think about all of this and look at these flow charts about how this whole thing works. So autoregulation, if all is good, this all happens locally. There's vasoconstriction, vasodilation, and that is going to maintain the blood flow to the tissues. However, if there's any sort of if the autoregulation is insufficient, then we'll go up here into the green box and we'll look at the signals coming from the brain. Again, this is all autonomic nervous system. This is all involuntary. Or we'll also look at the effects of hormones. And those hormones can increase blood flow and as a result, or decrease, and as a result, restore homeostasis. Now, there are two regulatory mechanisms that are going to be helping the nervous system and the endocrine system know when they need to step in to help with this perfusion. One are the baroreceptors. You've heard about these before. Baroreceptors are pressure receptors. They're going to respond to changes in the blood pressure, and they're going to be located in the carotid sinuses. The carotid sinus is basically where the common carotid and the internal and external carotid arteries branch off. It's in this area where the carotid sinuses are. The aortic sinus, this is in the aortic arch, and in the right atrium itself, there are some baroreceptors. So again, read through these tables, and this will be very helpful for you. But if there's a decrease in cardiac output, then you're going to stimulate, okay, increased baroreceptor stimulation is a decrease in cardiac output. That might be due to parasympathetic activity or an inhibition of sympathetic activity. Responses to decreased baroreceptor stimulation. So if there's less pressure being put on the baroreceptors, then that's going to cause an increase in the cardiac output, and that's going to stimulate sympathetic innervation. So again, if there's too much pressure on the heart, these baroreceptors are going to say, let's cool it down. If there's not enough pressure, and now we're worried that there won't be enough perfusion to the tissues of the body, then we're going to increase the cardiac output. So if there's a decreased blood pressure, then the baroreceptors will be inhibited, and this will now stimulate the cardioacceleratory centers, increase the cardiac output. There would also be vasoconstriction that would occur. That vasoconstriction would squeeze down and increase the pressure, and that would help restore the blood pressure back to normal. If, however, there is an increase in blood pressure, those baroreceptors will be stimulated. Basically, we're telling the heart we're being overworked, there's too much pressure. This is going to throw in some inhibitory signals, decrease the cardiac output, open up the vessels, vasodilation, again restoring the blood pressure by reducing it back to homeostasis. So we have to keep that blood pressure within that normal range, and these baroreceptors are a big part of that. So the baroreceptors are part of the nervous system responses, and then there's also some endocrine responses that can occur. These can be both short-term and long-term regulators of cardiovascular, and we're going to see that there are endocrine functions of the heart, of the kidneys, and of the posterior pituitary through ADH that are going to affect blood pressure. So hormonal responses to low blood pressure. If there's low blood pressure, then immediately there can be a release of epinephrine and norepinephrine, and this will come from the adrenal medulla. There are other long-term hormones that are responsible for regulating blood pressure: ADH, angiotensin II, erythropoietin, and aldosterone. And we'll mention each of those and what their role is in regulating blood pressure. So another wonderful flow chart. So we see that in short term, homeostasis is disturbed of blood pressure. Keep in mind that that can be a decrease in blood pressure and or volume, because a lower volume of blood would also decrease the blood pressure. So in the short term, there can be sympathetic release from the adrenal medulla of epinephrine and norepinephrine. In the long term, we're going to have renin released from the kidneys. Renin is going to activate angiotensin I, converted by ACE, angiotensin converting enzyme, to angiotensin II, and that's going to have, angiotensin II is going to have the following effects. It's going to have widespread vasoconstriction. If all the vessels are squeezing, then that's going to increase the pressure. It's going to release ADH. Remember, ADH is going to, antidiuresis is going to increase volume in the body. That's going to increase pressure. It's also going to secrete more aldosterone, and thirst will be stimulated. There's also erythropoietin coming from the kidneys that's also going to increase blood pressure. If the blood pressure decreases, then that's also going to up the number of red blood cells. And so increased red blood cells will also increase blood volume, and these features will all increase blood pressure. Together, we're going to bring the blood pressure back to normal. Now, the heart is also releasing hormones. These are atrionatriuretic peptides. There's also a brain natriuretic peptide. When the heart wall is stretched during, when there's high volumes of blood and the heart wall gets stretched, that's going to release from the cells of the atria natriuretic peptides. This is ANP. The brain also, from the ventricular muscle cells, will be releasing BNP. And again, if you have high pressure on the walls of the heart, then you would want to decrease the blood volume and decrease the blood pressure, and that is done through these hormones. These hormones, natriuretic peptide released by the heart, is going to go to the kidneys and increase sodium loss in the urine. Well, of course, solutes suck, or the water will follow those solutes. There'll be an increased water loss. There'll be a reduced thirst, inhibition of ADH and all the other hormones that we talked about, and a peripheral vasodilation. All of that is going to combine to decrease the blood volume and decrease the blood pressure, bringing homeostasis back to normal. In addition to baroreceptors releasing signals, and also the ANP and BNP, there are also chemoreceptors. Chemoreceptors are going to be responding to changes in the chemistry of both the blood and the cerebrospinal fluid. And they're going to be responding to changes in CO2, oxygen, and ultimately the pH. These are located in similar places to the baroreceptors, the carotid bodies and the aortic bodies, similar to the carotid sinuses and the aortic sinuses, and also along the ventrolateral surface of the medulla oblongata. They are going to, along with baroreceptors, help coordinate changes in the cardiovascular system, and we'll see these chemoreceptors come back again when we get to the respiratory system, and we'll see how they also are involved with controlling your respiratory function. So again, as CO2 levels increase, remember, more CO2 is more acidic. That's going to decrease pH, right? Lower pH is more acidic, and where there's increasing CO2, there would also be decreased oxygen. So we can see that if the chemoreceptors are stimulated through this increase in CO2, that's going to have an effect on your cardiovascular center by stimulating it and also inhibiting the inhibitory center. And vasomotor center will be stimulated, so you'll have more blood vessels going, or more blood going into the capillaries. We will see this again later on, but the respiratory centers in the medulla will also be stimulated. That's going to increase the respiratory rate. All of this in the heart is going to cause the cardiac output to increase, the blood pressure to increase, and that is going to help get rid of the CO2, this acid that's accumulating in the blood. Decreasing those CO2 levels will increase the pH and increase the oxygen levels, and that should bring everything back to normal. So the last thing we'll discuss is what happens to the cardiovascular system during exercise. So at rest, cardiovascular cardiac output is about 5,800 milliliters per minute, roughly 6 liters per minute, just to keep that in mind, roughly 6 liters per minute. During light exercise, what's going to happen? There's going to be some vasodilation occurring that's going to increase your openings of your vessels, and that's going to drop your peripheral resistance, and the capillary flow will increase, right? Because your tissues need more oxygen for the exercise, especially the muscles, and so you're going to have some capillary flow increasing. Venous return will increase with the skeletal muscle contraction, so as you're exercising, that blood will be pumping back faster, and this will also increase your respiration rate, which is your respiratory pump. So not only is blood returning to your heart because of the skeletal muscle pump, but also because of the diaphragm. And as you breathe faster, there's also a thoracic pressure change that brings blood back to the heart more quickly. And during this light exercise, cardiac output will increase to about 9.5 liters per minute. During heavier exercise, cardiac output can go up to as much as 17,500. Right, so up to 17.5 liters per minute. So amazing differences. And again, what you've got going on here is you've got a lot more flow of blood going to your skeletal muscles. You have increased blood flow going to your skin to promote heat loss. And as you know, during this sympathetic type of activity, you would have less blood flow, therefore going to your viscera and your kidneys. But your blood-brain flow will remain largely unchanged. The flow to the brain must stay the same. So looking at this as a picture then, 750 mils at rest to the brain, and no matter what your exercise levels are, it'll stay the same. We will see a huge difference will be in the output of your heart from about 5,800 mils to 9,500 up to 17,500 or so. And what you'll see is that the kidneys are going to get less over time, from 1,100 to 900 down to 600. The viscera also going down, 14, 11, 6. Skin will go up to get more heat off. Other tissues overall will go down, and your muscles will continue to increase, with the muscles getting the largest change. So huge amount going to the skeletal muscles during heavy exercise. Now, it is true that trained athletes have bigger hearts and higher stroke volumes. Now, typically you wouldn't want a larger heart, but a bigger heart in this case is also going to increase the amount of blood flow that can occur. In fact, that bigger heart and those higher stroke volumes, a highly tuned athlete can have a very, very low heart rate. As low as 32 beats per minute, and still maintain a normal cardiac output at rest. And maximum cardiac output could be even 50% higher than non-athletes. So athletes do train their heart and train the rest of their body to respond to exercise in a more efficient way. So what happens then during blood loss? When there's some sort of failure of the homeostatic mechanisms to prevent significant blood loss, then the entire cardiovascular system will compensate immediately through changes in blood pressure and peripheral blood flow, long term trying to restore that blood flow. So again, short-term responses. When you stand up, there's going to be a change in just laying down to standing up. Your carotid and aortic reflexes are going to increase the cardiac output so that your heart rate stays pretty much the same. If you're stressed out, that's going to stimulate the sympathetic nervous system. That's going to increase your blood pressure, and you'll also see the effect of epinephrine and norepinephrine from the adrenal medulla on short term. Other things are more long term, such as ADH. Long-term responses to blood loss, decrease in capillary blood pressure, aldosterone, helping to keep fluid in the body, going to the kidneys. Thirst will increase, and erythropoietin will stimulate the maturation of more red blood cells. Again, if you have less blood, you would have less perfusion, and one way to fix that might be to call upon more red blood cells. So if there is an extensive bleeding going on, therefore decreased pressure and decreased volume, then there's going to be responses from your endocrine system and from your nervous system, as you can see here. There's going to be, of course, the pain or the anxiety of bleeding out or bleeding, and so that's going to stimulate the cardiovascular system and increase your heart rate and your blood pressure. Baro and chemoreceptors will be responding. Hormonal signals will also be responding, and collectively that's going to increase your cardiac output, elevate your blood volume, and hopefully restore homeostasis. Now these are two relatively small blood losses. If it is a very significant blood loss, imagine this increasing, but of course at some point if too much blood is lost, then these effects would be meaningless because the blood pressure would not be maintained to the brain and to other tissues. When there is a blood loss, then there's going to be shock. Shock is basically any time where there is a drop in blood pressure, any kind of hypotensive change, and it's due to inadequate peripheral blood flow. Most common causes are going to be bleeding and heart damage. So the heart, in a heart attack, then the blood is not flowing adequately. And these homeostatic mechanisms that I've just described would not be able to necessarily compensate. So if you're bleeding out significantly or have a heart attack, clearly the homeostatic mechanisms are not going to be able to restore that blood flow. There's also circulatory shock, and this is if you have blood loss at greater than 35%. Okay, you're going to have a circulatory shock type mechanism. There's also progressive shock, so the blood volume drops by more than 35%, and no matter what happens, the blood pressure is going to stay low, the venous blood will be reduced, the cardiac output will be inadequate, or if there's a heart attack, then you're going to be damaging the myocardium and further reducing cardiac output in the future. Reduced cardiac output will accelerate the lack of oxygen to tissues. There'll start being some clotting and some other problems in the flow, and there'll be huge changes in the local pH changes in the capillary permeability. So there would be autoregulatory changes trying to occur, trying to increase blood flow. Irreversible shock. Basically, the baroreceptors are going to trigger sympathetic, a lot of widespread constriction. This is going to reduce peripheral circulation, but increase the blood flow temporarily, just to keep you alive, if you will. Without treatment, the blood pressure will again decline, and now likely there has been serious damage to the heart. At some point, all of this will lead to a circulatory collapse where there'll be widespread dilation and pretty much a immediate and fatal decrease in blood pressure and stopping of blood flow. So we're just looking at what happens, over time as the heart stops or as there's a big bleed, what begins to happen as we go through these progressively worse situations clinically. So that's shown here in this diagram. So any sort of reduction in blood volume or damage to the heart muscle, right? And you can begin to see what happens. There'll be a decrease in cardiac output, a decrease in pressure. Yes, there'll be feedback loops to try to restore that, but if that's not able to restore it, then you'll move into the purple over here where you've got maximum vasoconstriction, irreversible muscle damage, a decrease in arterial pressure, which again, there's a positive feedback going on, but if that's not able to restore it, then you'll be in circulatory collapse and ultimately death. So that brings us to the end of the second talk on cardiovascular system. Please take a look at the homework assignments and the quiz that is assigned will help you. The homework assignment does have an adaptive follow-up. So after you have done your homework assignment, if you have not made a 90% or better on that, you will be asked to do a second assignment that will help you with the specific areas where you had weakness in. So look at the deadlines very carefully. Some of the deadlines are set up to be midnight on some evenings. Other deadlines are at 4:30 in the afternoon or at the beginning of class time, so that you are prepared for lecture and ready for the presentation and for the review. So this finishes up cardiovascular system. The next discussion will be over blood.